Welcome back to the RX class. I'm your host, Dr. Guang Chen. Again, I have a very special guest, long-term friend, Dr. Gaurav Sutrave. He's a general and transplant hematologist working in Western Sydney, Australia. We talk all things hematology, blood, and the new advances that's coming our way. It is probably one of the most exciting conversations I've had in a long time. Before we proceed, note that throughout the podcast episode, information presented is general in nature and used at your own risk. Complex concepts may be oversimplified for entertainment purposes. Symptoms and medical conditions, as well as the diagnosis and treatment of these conditions, may be mentioned. The information presented does not constitute the practice of medicine, nor replace the medical advice from a licensed medical professional. Do not rely on the information to make decisions about your or someone else's health. Please seek help from a certified health practitioner if you have concerns or symptoms. Please enjoy my conversation with Dr. Gaurav Sutrave. Hi, Gaurav. Thank you for coming on.
Thanks, Fun. Thanks for having me.
It's been a long time since we had the formal catch-up. I think it's a good opportunity to chat about hematology.
Yeah, no, well, I'm glad to be on, and I know it usually takes a bit of time in between these catch-ups, so it's always good to...
Can you tell us a bit about yourself and how you got into hematology?
Yeah, so I'm a clinical and lab hematologist at Westmead Hospital and New South Wales Health Pathology, which is the hematology lab attached to the public hospital. So I work both in the general hematology unit, looking after people with a wide variety of malignant and non-malignant blood disorders, but also helping out with the blood transplant and immune cell therapy service. So this is people having allogeneic bone marrow transplants. The other group of people who I look after. In my lab role, I'm responsible for helping report on some of the blood tests, which many of you or many people actually have. So, the full blood counts, looking at your different blood count levels, bone marrow biopsies, some additional more advanced molecular testing. But in terms of what made me interested in hematology and why I wanted to do it, for me, it was just something it was just as simple as this was an area which I found more interesting than other parts of medicine. It's just what stimulated my interest. I was particularly interested in the mechanisms of blood disorders like leukemias and lymphomas, and how we can use the immune system to help fight those types of disorders. And that's something which is really sort of really been a focus of a lot of my research, the research part of things which I do. So that's sort of why I dove in and why I started working at Westmead also, which has a very a very long history of looking after people with blood disorders, and in particular using immune therapies to help try and treat them. So that's why I am where I am doing what I'm doing.
Can you tell me what you do from a day-to-day point of view? I think you spoke that today was a meetings day, but what about on some of the clinical days?
Yeah, so it's really nice. Hematology sort of gives me a nice mix of doing both patient-facing work, so my as well as doing some lab work. So my a typical day for me would be usually a clinic in the morning, which would sort of last half the day. Then I would go up to the wards to do a ward round to look after any of my inpatients who are sort of getting more active treatment for a wide variety of different conditions. And then in the afternoon, I'm generally down in the hematology lab helping troubleshoot any problems which are happening over there, helping report on some of the helping verify some of the reports from the analysis which has been done on various different samples, and sort of helping and teaching some of the junior doctors who are also sort of learning to be lab hematologists. So I mean, that's sort of what takes up the bulk of my day. There's intermittent periods where I do head over to our associated research institute to sort of help out with some of the PhD students who are working over there also on some of their.
Oh, what an interesting day! I think I've got
lots of different bits and bobs, but I think that's one of the really appealing things about hematology, in that you can really sort of follow you can sort of follow people through the whole course of their journey, and you can see what happens to them on a day-to-day basis clinically, but you can also correlate all those blood test results which you're analyzing to try and figure out what's going on with people, because you get a real understanding of how the results are generated in the lab.
Well, look, perhaps for the listeners at home to get a better understanding of what hematology or the hematological system is, perhaps if you could give us a very simple or a simplified rundown of the blood system or the hematology system of how you see it and how you categorize
Yeah.
the different cell types or different types of cells.
So the blood is a little bit of a well, I'm sure every specialist will think that their organ is the most complicated organ, but it's actually not particularly complicated. So your blood consists of two components. There is the cells within the blood, and then there's a liquid component which is called plasma. So the cellular component consists of three different cell types. So it consists of red cells. So they carry oxygen around your body and give you energy. It consists of white cells. And so there's various different types of white cells that help fight off different types of infections. And then there's the platelets. So they're the bit that clot the blood and stop you bleeding. And so I don't know if you ever look at your blood report, you can go down to your full blood count, and those are the three that are usually bolded on your on the blood report. Um, um, Hematology deals with disorders of each of those individual different components. So the typical disorders with hemoglobin, are often people who are anemic. There's a group of people who actually have very, very high hemoglobins, and that's called polycythemia. That causes a different range of problems. Similarly, we look after people with low platelet counts, and they're more predisposed to bleeding. We look after people with high platelet counts who are more predisposed to clotting type disorders. And then we look after people with low white cell counts, so they can often have immune disorders or recurrent infections, or people with very high white cell counts who may actually have leukemias or blood cancers, which often we see high blood counts in that subset of people. We also look after people who have combinations of blood count abnormalities. So some people have all of their blood counts being low, and that's often a sign of a non-functional blood system, which can be due to a wide variety of different causes. The non-cellular part, or the liquid component or the watery component of blood, is called plasma, and that sort of consists of a wide variety of different proteins that are involved in different types of processes in the body and maintaining a healthy state. The main one, which we're usually concerned with as hematologists, is the blood proteins responsible for clotting. So there's a whole bundle of different clotting factors which will help prevent you from bleeding. So we, part of my day-to-day practice also involves looking after people who have, deficiencies in their clotting factors. And so the most common ones that people would know about are hemophilia. So as well as some other less common ones like von Willebrand's disease. And then there's people who have too much of their clotting factors, or clotting factors which result in too much clotting. And so these are a group of disorders called thrombophilias. And so these people are more likely to get deep vein thromboses, or DVTs, or clots in other parts of their body, such as the lung, which is called pulmonary embolism. And so we sort of help look after people with those types of disorders also. And they, and we sort of help manage either the blood thinning or the blood clotting factor replacement that they need. The other components in the liquid part of blood, there's a wide variety of other proteins which are responsible for other non-hematological functions. So we have there's antibodies in the blood that help fight off infections. There's albumin, which is a common carrier protein that sort of sits around. There's various iron binding proteins which are important in maintaining your hemoglobin. And so we sort of overlap with other specialties in helping look after people with disorders in those other blood proteins.
Well, thank you for the good summary. Yeah, I guess again, for some of the listeners at home, perhaps some people don't realize that I guess blood cells have a life cycle, and so they don't just get made and then they stay there for the rest of their life. And so perhaps just to highlight, if you were to use, say, the red cell as an example of, where does it start and where does it go, what happens to it? Does it get recycled? Do they get destroyed? And what happens along that pathway?
Yeah, so just like every other cell in the body, everything has its own lifespan, and the blood cells also have a defined lifespan. The thing with the blood component is that they're always being utilized relatively quickly, and they need to be replenished regularly. So the factory where all of your blood is made is called the bone marrow. So if you can imagine, like, everyone has bones around their body, and they obviously help maintain your skeleton. But all the bone itself consists of two components. There's the hard outer shell, which is called the cortex, and then there's the internal component, which is called the medulla, and that's generally it's inside of the bones in that sort of like meshwork medullary component where a lot of the blood is made. So in that bone marrow, you're always making more red cells, more white cells, more platelets to replace those ones which are being used up. So your typical red cell will have a lifespan of about 90 days, and so after 90 days, it sort of stops functioning. It gets a bit tired. If you can sort of imagine your red cells are whizzing around your body, several thousand times per day, and as they do that, they often have to sort of like squish through like small blood vessels and try and find their way around different parts of the body, and that does give them a bit of a beating, and eventually they sort of become what we call senescent. They lose the ability to carry out their oxygen carrying functions, and when that happens, they get chomped up by they get recognized as being non-functional. They get chomped up by different organs in your body and their internal components. Part of them get excreted out of the body. Part of them get recycled and reused for to make new blood whenever you need. So red cells are probably the longest lived part of your blood. The white cells often have a much shorter lifespan, so you're often talking in the range of hours to about a day, depending on the type of white cell you're looking at. Um, there is and so they need to be replenished very, very quickly, because you can imagine your body is always on the attack against different bacteria and viruses and fungus which sort of live in the environment. And so a lot of these white cells are sort of, run off trying to chomp away at any of these bugs which are coming to attack you. So they don't last as long. There is a small subset of your white cells called lymphocytes. They can be a little bit more long lasting, and they're what are responsible for giving you long-term immunity. And then finally, you have your platelets, which sort of help you stop bleeding, and they need to be replenished fairly frequently. Also, your typical platelet will live for about a week or so.
Wow. So is that why people can give blood donations regularly? Every 3 months, the body does regenerate all the
Yeah.
blood.
So when you go for your blood donation, you do donate your blood, but then it gets regenerated. Your body realizes that it's lost a little bit of blood, and then your bone marrow ramps up production to replace what it's lost. Similarly with stem cell donors, so like blood stem cell donors, who donate for stem cell transplant, those stem cells which we take off, they get replenished by your body and can sort of take the place of the ones that we can collect. So your bone marrow is always refreshing itself over and over again to make sure that you're always kept in balance.
And so with the blood donations, what actual part of the blood is used? I mean, can you explain that so people can? Is it only the red cells? Are the white cells used when they get in the machine? Are the platelets being used? And what about the
Yeah.
non-cellular components?
Yeah, so when you go for your blood donation, there's actually two different ways you can donate. You can donate what we call whole blood, and so that's sort of which is what we typically associate with blood donation, where we just take a bag of blood out. When you give a whole blood donation, what we do is we actually separate the blood into its different components. So we separate it out into the red cells, white cells, platelets, and then the plasma component. And then we store out the different components. So, as I was saying, the red cells usually have a lifespan of about 3 months. So that's generally how long you'd leave a bag of blood lying, like you'd sort of store a bag of blood before you could transfuse it into someone. The platelets can last a bit less. So again, as I said, about a week is how long you would keep the platelets. And then there's the plasma component, which contains a lot of those clotting factors, which are so important to stopping people bleeding. And so we often use them in people with bleeding disorders. But the plasma also contains a lot of like those antibodies which I was talking about, which help sort of you fight off infection. We often use them to help treat people who have recurrent infections. So we try and give them a bit of immune boosting. The white cells we don't routinely use in transfusion. They're often discarded, and the reason why is because the white cells don't live for very long. So it's really hard to be able to actually use them to transfuse into other people. The only scenario where we do use white cells is when we're trying to treat people who have like very serious life-threatening infections. Because one dose of white cells you give them and they're all gone within a day. So and often you need like multiple doses of the white cells to be able to help fight off these very, very serious infections. But But there are a lot of different side effects people can get with those, and so that's why we don't really commonly use the white cells that people donate.
Well, I guess that's probably the reason why we normally donate every 90 days or every 3 months. Is that because the red cells essentially have an expiry date? Is that how that's determined?
So it's more about don't like the safety of the person who's donating. If you if you try and take blood of someone too frequently, you don't give them enough time to recover their blood, and so that's why we give that 3 month wait period in between, because you don't want to be trying to collect blood of someone every week, because they'll become very very anemic and you could make them quite sick. So you want to give these people time to recover before they can donate again. Um, the other way that we can collect is through a process called apheresis. So there are some people who donate who donate plasma, and so when I spoke about us taking the plasma from one from a whole blood unit, we often need to pool plasma from multiple different donors to get enough clotting factors to treat someone. And so we can sometimes get around that by getting a single donor and collecting a larger volume of plasma off them. And the reason why we can do that is because your blood proteins can be replenished a lot quicker than your blood cells can. So we can take off larger components of larger components of plasma off a donor without causing any major problems, because they get replenished a lot quicker. So like within the day.
Wow. Okay. Look, I mean, I guess some people may know that you can't just receive blood from anyone. We have these blood groups. Can you briefly explain what ABO or rhesus is in a very simple way for people
So
at home?
Yeah, no two people are genetically identical, and so there are differences between different individuals, and so everyone has their own blood group. So there's only a very limited number of blood groups. It's AB, or O, and you need to get blood from someone who has a compatible blood group with you. So the way that we determine the group, like someone's blood group, is that we test for each of your red cells will carry a little surface marker. So the people who have blood group A will have an A marker. The people who have blood group B have a B marker on their red cells. The people who have blood group O have no markers on their cells. And so people who have blood group O are considered universal donors because they don't have any markers on their cells. So theoretically, you could put these unmarked red cells into anyone's body, and that person won't have a reaction to them. Whereas if you were to take someone whose blood has this A marker on it and try and put it into someone who is blood group B or blood group O, that person would actually recognize those blood group A cells as being foreign, like bacteria, and attack them, because they have that foreign A marker on them. So that's why you need to be able to try and give people blood which is compatible. So people who have blood group A can get blood from people who are blood group A or blood group O. People who are blood group B can get it from if you're B or O. People who are blood group O, unfortunately, while they can donate to anyone, they can only get blood from other people who are blood group O. And then similarly, people who have blood group AB, which is where their red cells will express both the A and B markers, they can actually are quite lucky because they can get blood from people who are blood group A, blood group B, or blood group O. Doesn't really matter.
I think I'm blood. Oh, I'm the
Yeah,
universal donor.
good donor, bad recipient.
But do these rules apply for the plasma, or anyone can receive anyone's plasma?
So again, with plasma, we don't. You do need to match the plasma also, but the plasma matching is actually in reverse to the blood group. And the reason for that is the way that people react to blood is that they have an immune protein within their plasma that actually causes the immune reaction or that causes the reaction to the incompatible blood. So in people who have blood group A, for example, their plasma will contain proteins that react to people with blood group B. So when someone with a blood group A donates their plasma, that plasma can be used again to treat people who have blood group A. It can be used to treat people who have blood group O, but it can't really be used to treat people who have blood group B because it would react against those B cells.
Ah, interesting. It's the reverse. Okay.
Yeah. So for plasma donation, blood group AB is the best because they don't have any of those proteins they don't have any of those plasma proteins that react against the other different red blood cell tagged blood cells. So
Okay. Now, you mentioned you also do some work with, I guess, transplantation. Um, can you tell us a bit about, I guess, how you transplant? It's not like an organ where you can move a heart from one person to another. How do transplants work in hematology or the blood system?
yeah, so stem cell transplant's a little bit different to organ transplantation in that your blood is, as we were saying earlier, it's completely replenishable. So whereas if you take a heart from a donor, they will die because you can't live without a heart. We can actually take out stem cells from a donor, and that person will be able to replenish the stem cells which we collect without any long-term adverse effects. So that's probably one good thing about stem cell donation in that anyone can be a stem cell donor if they're otherwise healthy, and you can donate stem cells on multiple occasions without any adverse effect to your health. Um, so I would encourage your listeners to join their local stem cell registry because we're always on the lookout for stem cell donors. But the way that stem cell transplant works is a little bit different to how solid organ transplantation works. In that, what we try and do is that it it's stem cell transplants really the only curative treatment for people who have chemotherapy resistant blood cancers. And the way that stem cell transplant works is that we find a stem cell donor, that we infuse that person's stem cells into the person who has the blood cancer, and those stem cells are capable of actually recognizing the recipient's leukemia or lymphoma or other blood cancer as being bacteria, as being foreign, and it attacks those leukemia cells and kills them off. So basically, what we're trying to do with a stem cell transplant is induce blood cancer immunity within the recipient. Um, so while it sounds simplistic, there's a lot of things that there's a lot of problems that can happen with stem cell transplant. So we don't take we never take the decision lightly to do a stem cell transplant for anyone. And probably the biggest challenge is finding the right donor for people. So just like we spoke about blood groups, like red cell blood groups, people also have a stem cell group, and so we need to match people across their stem cell groups also. So the stem cell matching is a little bit more complicated because while with blood groups there's only those four blood groups A, B, AB, and O. With your stem cell blood group there's actually 12. So finding a donor is a little bit more challenging because we've got to match across 12 different blood groups. Oh, well, immune groups. Sorry, we have to match across 12 different immune groups.
Wow. Okay. Well, perhaps Gaurav, talk through to how you would, I guess, approach a typical patient that may come to see you. Perhaps they may have had an abnormal blood test, or they may have some symptoms, and how do you kind of structure your thinking around how you investigate and perhaps categorize, and then ultimately develop a management plan for patients with perhaps a blood disorder.
Yeah. So like we sort of get referrals for a wide variety of different blood disorders. So I mean, the most common types of people I look after are people with blood count problems. And so typically when I do see when I get a referral from a GP for someone who's got a blood count problem, I guess the first thing is you have a look and see what is the blood count abnormality. Is the blood count high? Is the blood count low? Is it just one blood count? Is it multiple different blood counts? Obviously, it's really important to talk to the person who's come in to try and see whether those blood count abnormalities are making someone feel sick, and see what those types of symptoms are. So, in people who are anemic or have low red cells, often you can feel quite tired and washed out. You can feel short of breath. People who have low white cell counts can often have problems with recurrent infections. And people with low platelets will often have bleeding type problems, typically, sort of like gum bleeding or really like recurrent nosebleeds, or easy bruising. Um, once we got a bit more of a feel for like what sort of problems or what sort of symptoms people are experiencing, then we can sort of do an examination. Like I do an examination to have a look and see whether or not there's any clear abnormalities that I can detect. And then in terms of trying to investigate, well, blood count abnormalities are either due to problems with the way that the bone marrow is making the blood. So it's either making too much blood or failing to make blood, or it's a problem, or the blood is getting lost somewhere. So it's getting chewed up or eaten up or through different processes. And so the different investigations that we would do in that circumstance would be to try and evaluate, well, is there a problem with blood production, which can be due to low vitamin B12 levels, low folate levels, iron problem like low iron levels. It can be due to some immune disorders or infections, or it could be due to a blood cancer. If the blood levels are too high, then that is generally due to a condition where the bone marrow is a little bit hyperactive, and that generally happens due to a group of disorders called myeloproliferative disorders or MPNs. In terms of trying to investigate whether the blood is being destroyed too quickly, so it could be due to bleeding problems. So people who have bleeding either from their gut or heavy periods, particularly in young women, that can cause iron deficiency or anemia. Sometimes blood can get destroyed through abnormal immune processes, and so we can screen for those types of disorders also. If we're particularly worried about blood cancers, we would sometimes do bone marrow biopsies, which are a type of test where we actually take a sample of the bone marrow, which is the factory where the blood is made. We take a sample of that out and analyze it in our lab to see whether or not there's any abnormal blood cancer cells within the marrow, because that's usually where they live. There are other types of blood cancers called lymphomas, which often cause enlargements of lymph nodes around the body, and they're another different type of blood cancer. And so, if that was a concern, then we would go and do some scans to have a look and see whether we can find any enlarged lymph nodes anywhere in the body.
Oh, wow. I guess there's lots and lots of things to think about.
Yeah, so I mean, just like any other subspecialty, there's lots of different things which people can come to, because the hematological system, there's so many different components to it, and so there's so many different things, like so many different problems which people can have, and so it's just a case of trying to work through the problems with the patient, coming up with a rational strategy to figure out what's wrong.
Has advancements in technology and I guess pharmacotherapy changed the outcomes for many of these common blood disorders in the last 10, 20 years?
Yeah, so there's been an absolute explosion in the number of different treatments for people with blood cancers and non-malignant or non-cancerous blood disorders. The sort of main advancements have been in the development of new drugs to more selectively kill off blood cancer cells. But also in the development of immune therapies, where we harness the power of the body's immune system to get the immune system to do the work of killing off these blood cancer cells. So that's a particular area of research interest of mine, and it's the evolution of these immunotherapies has really sort of come to the fore with advances in genetic engineering technologies, where we can sort of engineer people's immune cells to actually recognize and kill off blood cancer cells.
And so how does that work? You harvest the white blood cells and then you engineer it externally and then you reinfuse them back? Or is that how it would work?
So in Australia, there's now, there'll soon be 4 different products available, like cellular immunotherapy, genetically engineered products available on for the treatment of different types of blood cancers. And so the way that we do that is just exactly how you described, Guang. We would collect people's immune cells. We would send them off to a manufacturing facility where they will be genetically engineered to target people's blood cancer. And then they're shipped back to us, and then we can actually infuse them back into people with blood cancer to treat their.
Well, that's very exciting. But I mean, in the last little while, I did hear about, I guess, also new gene therapies available, where I guess you can presumably infuse something to modify the underlying genes. And I think the particular example was in patients who have underlying congenital sickle cell disease, where I guess to my understanding, they have a small genetic defect in the red blood cell, which obviously causes them to have a sickle shape, and that can cause problems. And I understand there is, I guess, approved therapies to help improve patients um, in those kind of situations.
Yeah, so with sickle cell disease, the gene therapy is a little bit less advanced than what it is with some other types of disorders. So hemophilia is probably the main blood disorder where we're seeing a lot more gene therapy being used. And so what you can actually do is you can that there's various different methods by which we can genetically engineer cells. And so what we can do in some people with hemophilia is that we can infuse, we don't need to collect any cells from them. We actually give them a treatment which actually will go directly to the liver and genetically engineer liver cells to make the extra clotting factor which is missing in these people with hemophilia, and that can sort of re-establish normal blood clotting in these individuals. Similarly, there's also gene therapies now which are sort of in more early phase clinical trials, which look at trying to re-engineer people's immune cells to fight off leukemias and lymphomas also. So you know how I was speaking about, well, we have to collect for the current gene therapies that we have to collect your immune cells, send them off, and they need to be genetically modified outside of your body in a factory. We can sort of bypass that step, and we can infuse a drug, and that drug will genetically engineer the immune cells in your own body to help fight off those leukemia and lymphoma cells. So there are sort of these progressive advancements being made in the field of both gene therapy and in vivo gene modification.
Wow, that's very, very exciting. And would you say that these are the new frontiers, probably for the next 5, 10 years? Would there be any
Yeah,
other exciting advancements coming through the pipeline?
look, I think they really are. So I think a lot of blood cancers, at least, are part of it is part of the main deficiency is that your body's immune system doesn't know how to get rid of these cells. And your body's immune system is very, very efficient at doing what it needs to do. It's incredibly efficient at getting rid of bacteria and fungus and viruses and stopping you getting sick from those bugs. And so everyone has the sort of raw materials that they need to be able to kill off their leukemia cells. It's just your body's immune system obviously doesn't recognize those leukemia cells or lymphoma cells or cancer cells as being foreign because they're part of you. So if you so with an increased understanding of the differences between cancer cells and healthy cells, we're able to sort of exploit those differences that the cancer cells have and highlight them for the immune system so the immune system can kill them off.
Oh, yes, I'm very excited to see what's to come. Oh, thank you so much, Gaurav, for your time.
That's okay. Thanks for having me on.